Well, good evening, everyone, and welcome to the IMS first teleconference of the new year. And I have to say, it's going to be a very informative one. Our speaker tonight is Dr. Brian Dury, and his talk is entitled Best of ASH 2015, What Myeloma Patients and Caregivers Need to Know. Now, ASH, which is the American Society of Hematology, is the premier meeting of the year, and thousands of people from all over the world travel to attend this very important meeting. So it's wonderful that so many people are listening to the call tonight. As Dr. Dury will be presenting a recap on the most important developments and advances in treating myeloma that were presented at ASH, and of course this information is invaluable. Before I turn it over to Dr. Dury, I'd like to take a moment to thank our sponsors of tonight's teleconference, Amgen, Bristol Myers Squibb, Celgene, Janssen, and Takeda Oncology. It's really wonderful that they support this program, and it's greatly appreciated. And one last thing, as a reminder, you'll find the link to tonight's slides, if you haven't already done so, by going to our website, and under New and Noteworthy, which is on the right-hand side of the page, it's that first bullet down. That's the link to the slide, so just click on it, and you'll be all set. So now sit back, relax, and Dr. Dury, it's all yours.
Well, thank you very much, Susie, for that kind introduction. I'm very pleased to have a chance to give this update from ASH. The ASH meeting in Orlando, Florida was obviously a very busy, hectic meeting, and since then we've all been very busy and active and thinking about other things over the holidays, and so I think it's helpful to step back and look at the data that was presented at ASH and see what does this mean moving forward in 2016. And so this presentation is going to be a little bit more reflective, thinking about the data that was presented and then what does it mean for patients and doctors and for the myeloma field in general. And so if you go to the first slide after the cover slide, bottom line takeaways from ASH 2015, you'll see that I've listed the top 10 items from ASH 2015. And this list includes 3 drugs, and as you probably remember, right at the end of the year, in the last 2 weeks of November, 3 new drugs were approved, Darzalex, Ninlaro, and Empliciti, and those data sets related to the drugs were presented at ASH. And so I'm going to give updates on those 3 new drugs, which I think is very important heading into 2016. Then after that, patient preference indicates the fact that with these new drugs and then all of the not-so-new drugs, we have a lot of choices. And the question is, how does a patient decide which option to implement? And the preference of the patient is obviously a key aspect of that in the decision process. And then after that, I've itemized 6 other topics, which were the key topics at ASH this past year. Minimal residual disease, frontline triple therapy, the role of autotransplant, imaging, new drugs, and then the use of an antibiotic, doxycycline, actually, for the treatment of amyloid. So I'll be talking about each of those 10 topics. Just to keep it easy for you as I go through my presentation, I've numbered those 1 through 10. And so if you go to the next slide, item number 1 is Daratumumab, and the commercial name is Darzalex. Fortunately, in this case, the original name and the commercial name have the DAR in it, which makes it a little easier to remember and to connect those 2 drugs. For those of you who are interested, the way I've structured this talk is that there are bottom line summaries, but there are also some statistics and curves and different things thrown in there. For those of you who love that, I hope that those will be sufficient. For those of you who maybe hate that, I also have just the bottom line takeaways, and so hopefully for both of you types of patients or people listening, this will be a good way to approach it. For Daratumumab, The first point is that this is approved for use as a single agent, which means that Daratumumab works by itself. You can take Daratumumab and it produces a response for the myeloma, giving it alone. This was approved on November 16th by the FDA, and it was approved in the setting of patients who've had prior therapy. In this case, at least 3 prior therapies, and a little bit separate category, any patient who is what's called double refractory, meaning that they have had myeloma progress taking one of the IMiDs, which would be Revlimid or pomalidomide mostly, or a proteasome inhibitor, which would be mostly Velcade or Carfilzomib. So for those kinds of patients, Darzalex was approved. It is the first monoclonal antibody that has been approved for myeloma. Well, there's a second one now, but this was the first one as a single agent, and it works against CD38. So what is CD38? It is an antigen which is on the surface of essentially all myeloma cells. So this is a receptor on the surface, and the antibody binds to it. And so one simple question I often get is, okay, if CD38 is on all of the myeloma cells, well, why doesn't the monoclonal antibody wipe out everything? And that's because of several factors, but one of them is that there's different density of antibodies, of antigens, so that there are different numbers of these receptors on the cell, and then the effect when the antibody attacks and binds to the receptor can be different from cell to cell. So even although all myelomas have this receptor, it is not universally potent. This is an antibody that is given by IV infusion. First couple of months given every week. The next 8 doses are given every 2 weeks, and then it's given monthly. If you go to the next slide, Dr. Usmani presented a combined analysis. There have been a couple of major studies using the Darzalex, and he combined the results from those 2 studies, and the overall results are indicated on the right-hand side of this efficacy in the combined analysis slide. And you can see it has some different colored blocks there, and you'll see an orange block which says 18%. So 18% of the patients had a partial response, which means the myeloma improved by 50%. And then you can see some different colors above that where the response was better, very good partial response or better. So that means a 90% response or even better than that. And that gives what's called an overall response rate, which is a PR or better of 31%. And so this 31% using the 16 milligram dose, this was a higher dose. In this case, the higher dose worked better. This is really a fantastic response rate for an antibody given by itself. If you go to the next slide, which is called progression-free survival, you'll see that the length of the remission, what's called the progression-free survival, if you look at the top curve there, which is kind of a lavender color, which says responders, these are the patients that had this 50% response or better, and then you'll see that it has a 7.4 number. What that means is that the average length of the remission was 7.4 months. And so this is really also quite good for treatment in patients who've gone through pretty much every other prior therapy. If you go to the next slide, you'll see that the overall survival was also quite encouraging for this type of a refractory patient, a patient, as I say, that had pretty much all of the previously available drugs. And you can see the lavender line at the top here, 19.9 months, basically 20 months of survival. So this is really very helpful as what we would call a salvage regimen to get the myeloma back in remission and also have an opportunity to have another drug available after that if needed. And you can see, if you look at the very bottom of this slide, the 1-year overall survival rate was right around 70%, 69%. And so, again, this is a very, very helpful salvage regimen and clearly a very active drug. And as you might imagine, there's now an intent to use this much earlier in the disease to see what additional benefit could be achieved. And so, next slide, number one, what's the bottom line for number one, Darzalex? Well, Darzalex is obviously a key new agent and is the leading monoclonal antibody in myeloma, and we're going to be hearing a lot about this agent in 2016 and the coming years. So if we go to number two, Ixazomib, the trade name for that is Ninlaro. If you look at this backwards, ORAL is oral, which tells you what this drug is. Well, this is an oral proteasome inhibitor. This is kind of a tricky part of this name. So it's the first oral proteasome inhibitor and got approval on November 20th. This was not approved as a single agent, however. It was approved as part of a combination. And so in the trial, half the patients received Revlimid and Dex, and the other half received Ixazomib Rev Dex, so IRD versus RD. And these were patients that had received 1 to 3 prior therapies. The Ixazomib is given by mouth on days 1, 8, and 15 of the monthly cycle, of the 28-day cycle. So the results with this, you can see on the next slide, key efficacy data, and you can see IRD, and then you can see RD, and you can see 20.6 months and 14.7 months. So basically, there's around 5-6 months added benefit in terms of the length of the remission with the combination, the 3-drug combination versus the 2-drug combination. So a clear added benefit with the oral proteasome inhibitor. But obviously, a key aspect of this is it's kind of like Velcade, but it's by mouth. And so the aspect that's important is that it's oral. And so number two, the bottom line about Ixazomib, it's the first oral proteasome inhibitor, which makes it quite accessible for oral combination therapies, and there's a lot of interest in how it can be used as a maintenance therapy. As you know, proteasome inhibitors can be used in patients with the 4-14 translocation, for example, and so if there was a need for maintenance with a proteasome inhibitor, this could be an ideal choice. So although it's approved in combination with RD, there are lots of ideas of how this drug might be used moving forward. Number three, move to the next slide. This is elotuzumab, and the trade name for this is Empliciti. Not quite sure where they came up with that one. But anyway, this is also a monoclonal antibody, so this is actually the second monoclonal antibody, but it does not work so well as a single agent. It doesn't work really well at all as a single agent. It's against an antigen which is called SLAMF7. This is something that is present on myeloma cells, but also on immune cells, in particular a type of immune cell called a natural killer cell. The good thing about this is that the killer cells are killing the myeloma. And the idea is that the monoclonal antibody would activate this process. And so this is an immune modulating or activating drug which facilitates the attack against the myeloma, not so much directly, but more by recruiting cells in the immediate microenvironment. It was also approved by the FDA. It was in November 30th in this case, but in combination with Revlimid and Dex. And so the studies were elotuzumab Rev Dex versus Rev Dex. It is also given by an IV infusion, weekly for 2 months and then every 2 weeks. We're going to be having follow-up calls and information this year about this type of an IV infusion. There are allergic and other kinds of reactions that can occur when you give a monoclonal antibody by IV infusion. And we're going to discuss a little bit about the length of these infusions and some of the precautions that are needed. I'm not going to get into that tonight. If you go to the next slide, this just shows you, well, what were the data with the elotuzumab, the Empliciti. And you can see here, if you look at the remissions at 1 year and at 2 years, that you have the dotted white lines. You can see with the 3-drug combination, it was 68% and 41%, and then without the 3 drugs, with just the Revlimid and Dex, the LD, lenalidomide and Dex, it was 57% and 27%. And so what people are excited about is that the gap between the 2 curves is maintained at 2 years, and then at ASH they showed that it was also maintained at 3 years. They had the 3-year follow-up. And you can see again in this case that it was a median, an average of 19.4 months versus 14.9. So again, an improvement in that 4 or 5 kind of month range in the length of the remission or progression-free survival. So bottom line for number 3 here, Empliciti, obviously quite important to have a new agent working by a new method, a monoclonal antibody, which modulates the immune system, particularly in terms of the recruitment of these natural killer cells which attack the myeloma. Okay, so number 4, this is just a small point really, but a very, very important point which is accentuated here after ASH for 2016. So we have these 3 new drugs. How in the world are we going to know when best to use those? How are we going to integrate those into the normal treatment protocols for myeloma patients? And Dr. Philippe Moreau, in his educational session with the IMF, our program on the Friday afternoon at ASH, if you go to the next slide, he had a very nice summary diagram which illustrates the decision process of how do you start to use these new drugs and integrate them with the old drugs. And so there are 3 circles here, kind of like the Olympics. You've got data from research, and that's basically where we are right now, and it's very, very important to realize this, is that we have data from research. Most of the doctors working with myeloma have maybe treated a few patients with these new drugs in the trials. They maybe have had a handful of patients in the trials, and maybe their patients did well or maybe not so well. And so clinical experience, which is the other circle on the left there, is rather limited at this point. So the doctors are learning, how does this work? How does it affect my patients? And then, of course, the patient is learning as well, talking to other patients and thinking about, well, how should this work for me? Do I want to go in once a week for an IV infusion? That Ninlaro seems attractive. Maybe I take that by mouth. Maybe that would be good for me. And there are a lot of issues to consider in coming up with that central piece in the middle, that decision. And so this is really a key aspect that I want to emphasize as we start 2016. There is a need for knowledge and patient knowledge. As Susie always says, knowledge is power. And knowledge for the patient, that time to discuss things with the doctor is increasingly important to figure out what is the best thing to do. So bottom line, patient education is key, and I would emphasize in addition, doctor education is also going to be key as they themselves learn how to integrate these new drugs into their ongoing clinical practice to achieve the best decisions. And so as we move to item number 5, this is the 5th, we're halfway through here in terms of the different topics. The minimal residual disease topic was the one for which there were the most presentations of any single type of topic at ASH. And so I would start off by saying that this was really very gratifying for me and also for the members of the Black Swan team and the IMF that has supported the Black Swan team to see that an idea that the Black Swan team had in 2012, a brainstorming group came together to think about how can we move myeloma research forward, and it was realized that if we could measure minimal residual disease, that was the key step in helping us understand how treatment was working at a very low level of disease and to come up with treatment that would go from a low level to a zero level. And so when I say gratifying, I would say that it's definitely a hot topic, and it's gratifying for me to see this and that people are picking up on this idea and realizing that this is indeed an important way to understand the impact of the treatment and to do the best job possible. Now, this is where I get into some of these numbers and statistics and things, and so for those of you who don't like numbers too much, you can maybe glaze out for a little bit, but there are some key points here. Next generation flow. This is a new flow method that was developed by the Salamanca team, supported by the Black Swan Initiative, to develop a new antibody approach so that when the bone marrow cells are run through this flow cytometer, the cells that have the antigens which are characteristic of myeloma are identified, and we developed a new 8-antigen or 8-color method which was significantly better than the old routine approach. And so down at the bottom you'll see I've highlighted some numbers in a red box, and so when we compared the new method, which we call the next generation flow method for detecting minimal residual disease, we picked up 15 new cases that were not picked up by the old method, and so that's a 25% improvement. So this was a really significant improvement that allowed us to get down to the level of where we could pick up 1 in a million cells. So that if there's 1 out of a million cells left in the bone marrow that was a myeloma cell, we were now able to pick it up. And so this information was presented by Dr. Alberto Orfeo from the University of Salamanca. If you go to the next slide, he also had enough data to compare this flow with a sequencing method which is called next generation sequencing. And I've highlighted the points here, one in red and the second one in blue. The first point is that the sequencing is not possible in every patient. There's just not enough DNA to do the sequencing and some of the technical aspects of the sequencing. And so this is fairly typical. They were able to do the sequencing in 78% of the patients. So the flow method, by contrast, is actually possible for every patient. And then if you look at the blue box, you can see, again, with the comparison of the totals, that results were available with the flow in 57 versus 36% using the sequencing. So, in fact, the flow was 21% better. And so, really, there is a little bit of a momentum to say that the flow is better, it's cheaper and more readily and widely available, and so this is something to look at seriously, although in our trials we continue to look at both NGF and NGS. We are continuing to compare these methods, but I would say for sure that we're, and a lot of attention was given to the fact that the NGF looks like it can be a very efficient way to go. However, whenever I talk about this sort of information with patients, their ears perk up at the sound of the words bone marrow. They say, now, could you repeat that? You said that this would be by monitoring the number of plasma cells in the bone marrow. And they want to know, well, maybe this would be possible by monitoring a blood sample. And so if you go to the next slide, the Black Swan team has now invested a lot of effort in trying to come up with a blood test versus a bone marrow test. And so the first thing that we did is that we applied this new flow method. And you see this next slide here is called Next Generation Flow to detect circulating peripheral blood clonal plasma cells. So this is basically to pick up myeloma in the blood. Now, this is a completely new idea for many people, the idea that there could even be myeloma cells in the blood. But if you go to the next slide, which says the distribution of cases with PB, peripheral blood clonal plasma cells. So this is the number of patients who actually have plasma cells in the blood. You can see 100%, that bar on the right there, 100% of patients actually have myeloma cells in their blood. Smoldering, 100%. MGUS, 65%. Even plasmacytomas, some patients have the plasma cells in their blood. So what we are now realizing is that quite probably by looking at the numbers of the plasma cells, we will be able to tell if a smoldering case is really active, if they have more plasma cells in the blood. And so this is where this research is going as a testing way to tell us early in the disease how active is the myeloma and how many plasma cells are there in the blood. But we are also investing in other types of technology, and one that is very, very interesting is cell-free nucleic acid. So what does this mean? This is looking at whether or not there is DNA, which is gene material, or RNA, which is the messenger RNA. Is there any DNA or RNA floating around in the blood? And the answer to that is yes. And Dr. Andrew Spencer, working with the Black Swan team, he is at the University of Melbourne in Australia. He has been looking at the pattern of DNA and RNA in the blood, and he's mostly been focusing on the DNA because it's more stable and easier to work with. And he has found that he can pick up the mutations which are in the DNA. So the myeloma cells have mutations in the DNA, and those mutations show up in the DNA, which is in the blood. And so if you go to the next slide, he has been tracking to see, well, what mutations show up during the course of the disease. And this here shows the pattern of a patient who started off with a CyBOR-D, VCD off to the left, and then had a stem cell transplant, ASCT, was in remission for 6-10 months, and then relapsed and received combination therapy and then got CyBOR-D again. And what I want to point out to you here is the blue line over on the right. You can see that the purple line at the end there went up and it went back down again with the VCD, but the blue line continued to go back up. And this means that there was a myeloma that had this blue mutation, which is a particular type of an NRAS mutation that was picked up in the blood at the point of relapse and continued to go up despite that relapse therapy. And so we're starting to learn about what are called driving mutations. There are lots of mutations, unfortunately, in myeloma cells, and you can pick them up in the blood. But the question is, what are the key ones that are linked to relapse? And obviously the question is, how do we get rid of those? And so this is the basis for part of phase 2 of the Black Swan project, where we're looking to see what therapies can get rid of myeloma that might have this type of an NRAS mutation. And so we are looking at this in a variety of ways, and this was also presented at ASH. And so, again, this was a gratifying aspect for our team, is that multiple team members had oral presentations at ASH. And so the German team, they also had a presentation, and they showed the results using imaging and molecular testing. And the DKFZ, that is the German Cancer Research Center, who collaborates with the Black Swan Research Initiative team. And so if you go to the next slide, just in one slide, what are they doing? Well, they're studying by biopsy results before and after therapy. And so up at the top, you can see a cross picture of the pelvic area of a patient, and the red and the yellow is the myeloma. And you can see there's a lot of red and yellow on the top left, And then, as you go down to the bottom right, you see a lot of the red went away, but there are some spots of red which are left. And so what the German team is doing a biopsy before and after, and they are able to test and see, well, what mutations are in this spot which continues to be red and is still growing despite the therapy. And so you can see that we're looking at every which way we can to figure out the details of the resistant disease. And so the gratifying thing is that this shows what are the new black swan strategies in the next 5 years. We can use the NGF for testing in the blood. We can also look at the molecular and probably other testing. And we can also have a variety of trials to look at patients to achieve MRD negative, which would be our cure trials, but then also to look at patients who have residual disease, which could be like an MGUS pattern or maybe a resistant disease with a RAS mutation requiring further therapy. And so these are very, very important initiatives moving forward. For those of you who might want to hear other opinions about this was discussed at the ASH 2015 conference series, and this is available on the IMF website, and it's the IMWG conference series, Making Sense of Treatment, MRD Testing, Is It Ready for Prime Time? And in this video, you can see commentary from Dr. Paul Richardson, Dr. Palumbo, and Dr. Joe McHale from the Mayo Clinic. And so I think you might find it interesting to see what is their take on the status of this MRD testing approach. So bottom line number 5, MRD is a new response endpoint for sure. Blood tests are in development and clinical trials are now ongoing. So let's move forward to the next major topics. So there were quite a number of papers looking at what is topic number 6, frontline therapy. And a key question was, is triple therapy the way to go? And the key question here is obviously, is it important to take 3 drugs as the first option versus 2 drugs? And I had the opportunity to present for the first time a trial that I've actually been working on for a number of years. This is the SWOG trial 777. What that means in the lingo is that I started to develop this trial in 2007. And it was activated in 2008. And so it gives you some idea of how long it takes if you want to have real outcome results. And so if you go to the slide, progression-free survival by assigned treatment arm, what this shows you is the blue line is the combination of Velcade, Revlimid and Dex versus Revlimid and Dex as the first line or primary therapy for newly diagnosed myeloma. And you can see that the remission duration was 43 months versus 30 months. So it was about 1 year longer using the 3 drugs versus the 2 drugs. And you can see those statistics, the p-values have got lots of zeros there. So this is good. If you go to the next slide, you can see the overall survival, and you may be aware that people are always very cautious about remission duration. They also want to make sure, well, did it really improve the overall survival? And so you can see here that the VRD, the blue curve, consistently stays above the red one. And again, you can see 2 things here. You have 75 months versus 64 months, which again is about a 1 year benefit. But you can also see that those are actually pretty good numbers. We're talking about numbers in excess of 6 years with just a 3-drug regimen. Now, these were transplant-eligible patients, but they did not receive transplant as a frontline therapy. So this is in the absence of frontline transplant. So this is just using the 3 drugs by themselves, and so really pretty promising results. So conclusions here. VRD definitely better than RD, 1 year improvement in both PFS and overall survival. In this particular trial, it was really quite distressing is that the Velcade was given intravenously. This was before we used sub-Q Velcade, and unfortunately we needed, within the trial, to stick with the IV Velcade, and so a number of patients had to come off treatment because of the neuropathy side effects. And so today, this would not be the case, and so using sub-Q Velcade, I think there would be substantially less neuropathy and maybe even added benefit with patients able to stay on this therapy a bit longer. And so we clearly think that the VRD is now a standard of care to be considered. If we go to the next study, which was from France, Dr. Philippe Moreau compared VTD with VCD, so another type of three-drug combination comparison. And so in this case, he was just looking at the response, and so after the initial 4 cycles of therapy, there were 66.3% VGPR or better versus 56.2%. So there was a 10% better response rate at the high level, greater than VGPR, with the VTD versus VCD. And so this suggests that those regimens are somewhat equivalent, with maybe a little bit of an advantage to the VTD. But my feedback from other investigators was that the Velcade, Cytoxan, Dex, people still do seem to like it. It's cheap, it's well tolerated. The VTD has obviously got thalidomide in it, and there's some neuropathy there. And so I would say that this is helpful data, but it certainly did not settle the discussion about the use of VTD versus VCD. In fact, in our conference series debate, Dr. Palumbo said he still really likes VCD. So anyway, bottom line, triple therapy does seem to be the way to go if feasible, watching out for side effects. And we have a number of options. VRD, which can be full dose or even reduced dose, which is light, which is a reduced dose schedule used by Dr. Paul Richardson at the Dana-Farber mostly, or VTD or VCD. So these are all excellent options, which need to be balanced with comorbidities, the age of the patient, and other kinds of risk factors. So a lot of helpful information about triple therapy. What about the role of autotransplant? Number 7, does autotransplant improve outcomes? And this has been something that has been up for discussion for several years now. The French part of this very large study, next slide, IFM DFCI 2009 study. You see, these studies have been going on for some time. Arm A does have the autotransplant, but it's only available at the point of relapse. Arm B, the high-dose melphalan at 200 milligrams per meter squared is given along with the combination of, they call it RVD versus VRD. You can see that, so there's frontline transplant with the 3-drug combination or not. And so very similar to the study I've just shown you, except half the patients, those in Arm B, did get the upfront transplant. And what you see, the IFM 2009 study, that there was about a 10% improvement in the VGPR rate, 88% versus 78%. Also an improvement, they're looking at MRD, 80% versus 65, achieved an MRD negative status. So a deeper response in the patients receiving the transplant. You can see that this is a large study. Even the French half of this trial had 350 patients in each arm, and 350 for both arms of this study, so 700 patients looking at the difference in response. If we go to the next slide, the PFS, the length of the remission, the progression-free survival, you can see that the remission lasted significantly longer with the transplant up front versus not. What is an open question, if you go to the next slide, overall survival, and you see 9 to this is from the September 2015 analysis. You see the lines are basically superimposable, and so right now there is not an obvious survival difference. And so although the French are really optimistic that there will be a survival benefit over time, I think that the skeptics are still waiting to see if this materializes, because there is in the one arm the option for transplant or relapse. But obviously, upfront transplant is really excellent, and I think that most people would say that if it's feasible, the results are really good, and that there are deeper responses that seem to be occurring, and there are more deep responses in the transplant arm. And so to try to bolster this argument, the French separately, Dr. Hervé Avelousseau separately in a separate presentation, he showed MRD after maintenance in the CR patients. And this is in the next slide. If you go to the next slide, it's a black and white title, MRD at post-maintenance in CR patients. You'll see that there are patients that achieved an MRD negative status. In this case, it was using NGS. This was using the sequencing method, which also works well at that 1 in a million level. 83% of the patients were still in remission versus 30%. And so this suggests that since there were more patients achieving a deep response in the transplant arm, that ultimately the remissions will be longer because there are going to be more MRD negative patients. But again, this was something that was actively discussed at ASH. People are remaining to be convinced about that. They need to see the data. So bottom line, autotransplant does improve outcomes, but we need to see more data to see the magnitude of the benefit, and this is going to be an ongoing topic, and the Dana-Farber part of the trial will be published, presented and published in due course. So if we go to number 8, very, very interesting data were also presented from this IFM study, this RVD with autotransplant study, looking at what were the results of the scans. All the patients in this study had PET-CT and MRI scanning done, and so this was really, really interesting to see the results of these scans. This was presented by Philippe Moreau. If you go to the next slide, PET-CT, they looked to see what happened to the PET-CT after the first 3 cycles of the RVD. 32% of the patients had a normal PET-CT at that point, and you can see that 78.7% of those patients were in remission versus 54.8% who did not normalize. So this correlated with a better remission. If you go to the next slide, they looked at the PET-CT after the transplant. So they had RVD, then they had the transplant, and then they had maintenance. So before the maintenance, at this point, 62% of the patients had a normal PET-CT. So you see the impact of the transplant there. And again, those patients had a better PFS or a better remission. If you go to the next slide, did this translate into survival? And so in this case, PET-CT normalization, so the PET-CT turned normal, and you can see this was 62%, and the survival was also better. So this supports the idea that the deeper response patients do better. If you go to the next slide, PFS for patients who had the negative PET and also had the negative MRD. So they looked at the MRD plus the negative PET, which was about half the patients. And again, in this case, 89.96%. So around 90% of the patients were in remission. And so if you use both of those, which is actually our new MRD response criteria, this correlates with a sustained remission. And that's why we've recommended to look at both of those tests. This is another outcome from the Black Swan project, actually, and is a IMWG guideline to be published soon. So conclusions, at the time of diagnosis, both PET and CT, PET-CT and MRI are effective at the initial diagnosis, but for monitoring, PET-CT after 3 cycles, PET-CT before maintenance, and PET-CT plus the multicolor flow CMF are complementary tools. So these are useful. Those are much more useful to monitor follow-up and the anticipated outcomes. So very, very helpful data. Number 8, the bottom line, these are just summary points about the imaging. For diagnosis, MRI and CT can be used. Whole body low dose is probably the most feasible. For monitoring, PET-CT much better, and is complemented by MRD. So number 9, what about the new drugs? And so what I mean by this is the ones beyond those 3 new drugs that were just approved, which are pretty new. So these are the newer ones even beyond that. And what I say here under number 9 is that it is getting to be a challenge. You've got all these new drugs. How do you say that another new drug is better or is needed? And so this is really quite tricky. And so if you go to the next slide, you'll see that under new drugs, I say, well, what are the challenges? So you can see that right now, in 2015, we had, for the 3 new drugs that were approved, they were exposed to 4 drugs. They were double refractory to IMiDs and proteasome inhibitors, and they were exposed to all 4 drugs: Revlimid, pomalidomide, Velcade, and carfilzomib. But only a small number of those were actually refractory to all 4 of those. And so this is now challenging us to think about how do we classify patients to assess an unmet need. Because now they're going to be multi-exposed. They're going to have had an IMiD, a proteasome inhibitor, maybe IV and by mouth. They're going to have had a monoclonal antibody, quite possibly. And so we're going to have a classification which indicates which agents have been used and whether the patient was exposed and or refractory to each one of them. And so it's getting a little bit complicated to assess the added benefit on top of what we already have. But nonetheless, if we go to this next slide, this is a diagram that shows the area of the greatest excitement right now. So the antigen receptor targets. Now, I've already mentioned 2 of those. In the right-hand part of the slide, in the blue box, you'll see CD38, and it has a green dot associated with it. And then right next to it, there's a green dot which is SLAM F7. And so those are monoclonal antibodies that have already been approved. But you can see that there are 4 other green dots there, and that's because there are agents that can attack those other antigen receptors on the surface of the myeloma, and those are either in trials or being tested. So other monoclonal antibodies, the CD46 and the LDLR, those are targets for virus therapy, and we've talked about that before, the use of the measles virus. Over on the left, you'll see that there are some red dots where these are antigens and receptors that are not present on every myeloma cell, but they can be the targets for treatment. And so if we look at the bottom red dot, which is CD19, that is present in only 4% of myelomas. However, this is the target for something which is called CAR T cells, and this has been a very popular topic where these activated T cells can kill the myeloma, but they have to have a target. And the most active has been against CD19, but it's only present in 4% of the patients. And I'll talk about that a little more in just a second. You can see that the NK cells can have different targets, and also the T cells can have different targets. And there are ways to manipulate that as well. So if we go to the next slide, one thing that was presented at ASH was the checkpoint inhibitors, which block the suppressive effect of the T cells. So this is the top part of my previous slide, the checkpoint inhibitors. There are drugs that will block that interaction so that the T cells can attack the myeloma. And data were presented for an anti-PD-1, pembrolizumab, and this is the keynote trial, and combined with Revlimid and Dex, very promising data, over 60% responses, and the same checkpoint inhibitor combined with pomalidomide and dex, also very active. A couple of oral presentations there showing that this can be a promising new approach. The CAR T-cell therapies, there was a late-breaking abstract using anti-BCMA, so anti-B-cell maturation antigen. So I said that the CD19 is only present in 4%, so people are looking at other antigens as targets. And so there were promising data from the NCI using the anti-BCMA CAR T-cell therapy. So this is quite a mouthful. All you need to know, bottom line here, is that these CAR T-cell therapies do look promising, although they do have quite a few toxicities, and it's not going to be trivial to develop those. A final comment that I want to make about these new therapies is how do we know that one therapy is better than another? One approach is to see if the therapy produces an MRD negative status. And what I already was talking about is how transplant will give you an MRD negative status on top of RVD. And this just illustrates here where you could show that one new therapy produces more MRD negative than an old therapy. And if this translates into an improvement in remission and overall survival, this could be a new way to approve a new therapy. And this is a very, very important approach because it means that you could have a short period of time for follow-up to show that the MRD negative status has been achieved and avoids 5 or even 10 years of follow-up to try to figure out if one treatment is better than another. And so this is another gratifying aspect of the Black Swan because this is something that has been part of this whole strategy. So, bottom line is that it's not so clear where do we set the bar for the assessment of these new drugs. Obviously, achieving MRD negative is pretty strict. We do want to pick up some drugs that are providing improved outcomes, but maybe in the big picture, we are really looking for a treatment that will give us MRD negative status. And obviously, with a new mechanism of action, which ones might be the most promising, we need to wait and see. And so the final point is kind of a small point, but it's very, very interesting. Topic number 10, an antibiotic, doxycycline, works for amyloid. This is certainly a new mechanism of action, and this was based on an observation that was published in Blood back in 2011, where it was shown in a culture system that the doxycycline reduced the amyloid deposits. And so it was decided to give, which you can see in the next slide, to give doxycycline along with regular therapy for the treatment of amyloid. And so the group in London, there's a very big and strong amyloid team in London with Dr. Hawkins in charge of the group. And he was able to show with his team, one of his team members presented this, that the patients taking the doxycycline did have better outcomes with better overall survival. And so the bottom line here is that this was an example of paying attention to that early clue and then following through and adding this into a larger study to show the overall benefit. So pay attention to those early clues. But as I finish here, I want to leave you with the final thought, which I've been emphasizing, is that there are a lot of new things. There is a drastic need to continue to understand how these new drugs are working, how these new imaging and other tests should be used. So be alert for education programs that might be available in your area. Certainly the IMF is going to be having quite a few of those, but any opportunity, take advantage of that, and then there will be quite a few new guidelines coming out as to how to best use the new therapies. And in my final slide, just to emphasize that we appreciate the support from our sponsors, as Susie mentioned at the outset, and so with that, I will close, and hopefully this has been a very good overview that will be helpful for you moving forward into the new year. So we can stop here, and we will have quite a bit of time actually for questions, and so please go ahead with any questions that you might have. Thank you.
Your first question comes from the line of John Bianco.
Thank you again, Dr. Dury, for the presentation. I just recently started carfilzomib as a single agent after a fourth relapse.
Okay.
I did that because a PET CT found 2 small bone lesions that had appeared.
All right.
My question is, how much time should elapse before I would consider doing another PET CT to see how those lesions are affected? And would you expect to see some movement in your kappa lambda and the M spike after about 2 months of treatment?
Yeah, so to answer the second part first, yes, certainly with carfilzomib, the response is often quite rapid. I mean, typically, the majority of the patients, the response is quite rapid within 2 or 3 months. You would certainly expect to see the light chains and the monoclonal protein improving. And actually, the PET scan result would also be improving rather quickly. We would tend to wait maybe 3 months or so, 3-4 months to repeat the PET CT scan, especially if the light chains and protein levels were improving. So if the light chains and protein were felt to be indicative of the disease, then we might wait even maybe a little longer to repeat the PET CT scan. But certainly the PET scan improves quickly, and so 3 months, if there was a concern, certainly by 6 months you would want to repeat the PET CT scan. And obviously with the carfilzomib, I talked about 2 drugs versus 3 drugs. You would certainly have the option, if you were seeing less than an ideal response, to combine the carfilzomib with something to get maybe even a better response if needed.
Yeah, we were thinking about pomalidomide, which was what I was taking with Velcade when
Yeah, so we have seen that. I had a carfilzomib pomalidomide trial. In fact, we just had our results published in Blood recently, and that 3-drug combination worked, even in patients who had taken the drugs separately as part of different combos, you know. So anyway, hopefully that's helpful.
Thank you very much.
Your next question comes from the line of Evelyn Enrick.
Hello. I'd like to find out a little more about what you mean by the MGUS signature on slide 26.
Yes, I'm sorry I skipped over that, but I'm happy that you brought it up and have a chance to discuss that. So this is something that is picked up actually at baseline this flow cytometry testing can be done at baseline, and then it's done at the point of maximum response. When you look at the pattern, there is a pattern which is characteristic of myeloma, but there's also a pattern of the myeloma mixture which shows up MGUS. And so when you treat the disease, in some cases you're left with the pattern which is characteristic of MGUS, the antibody distribution and other features. And so what this means is that in that case, if we do the follow-up testing and the MRD test is positive, but it just has cells that has this MGUS pattern, this is a situation where we might not need to push to have an MRD negative result, because patients who achieve just the residual MGUS, those kind of patients can do well without ongoing therapy. So this is an important subgroup of patients where we might want to be more cautious about pushing ahead to achieve MRD negative.
Okay.
So this is something that as these testings become more widely available, it's something that would print out automatically from the machine. This flow method has a computer software output, and so it's something that would be programmed into the output so that there would be a result which would be negative, positive, but this MGUS signature, positive, but a myeloma signature. So there would be 3 outputs, as I had on that particular slide, but I didn't explain it. So.
Okay, thank you.
Okay, all right.
Your next question comes from the line of David Watson.
Yes.
Yes, Doctor, thank you for the presentation. It was very interesting. Is there any advantage to having 2 upfront stem cell transplants versus 1?
So this is something that has been looked at quite a bit over the years. Obviously, the group in Little Rock routinely used the double transplant as part of what they call the total therapy, but unfortunately they did not have a control arm. In other words, all the patients got the double transplant, and so we didn't really see what might have happened if some patients had only had the 1 transplant. There are data from the IFM where the French group did look at the patients with the 1 transplant versus the 2 transplants, and this was not a randomized comparison, but their data showed that the patients who might benefit from the 2nd transplant were the ones who were not in a full remission after the 1st transplant. And so there is this idea that if you've had some benefit with 1 transplant but you're not in a full remission, their cutoff was VGPR, so that if there's like a 10% level left, there could be some benefit with the 2nd transplant. But there was a large randomized trial that was done in the U.S. which really did not show an overall benefit with the double transplant, and so I think it's an open question. I think that there is a subset of patients that probably do benefit, who have some benefit with high-dose therapy, but just need that 2nd transplant to get the full benefit. Right now, the double transplant is not really considered like a standard of care. It's something to be thought about or talked about, to be considered.
Okay, thank you.
Yes.
Your next question comes from the line of Kim Millman.
Yes.
Hi, I just have a quick question about the PET CT scan. Is there a concern with kidney problems in terms of filtering out the agents from the PET scan when you're talking about doing them on a regular basis?
No, that should not be an issue with the PET CT scan. The PET scan what a PET scan is that you get sugar, you get FDG, you get a sugar which has a fluorine isotope on it, so a radioactive sugar is given, and so this is not toxic to the kidneys. And then the CT scan is not directly toxic to the kidneys. So that's not really an issue with a PET CT scan. With MRI, we sometimes use gadolinium as an enhancing agent, and one does need to be cautious about the gadolinium contrast with an MRI scan. And so generally I suggest against gadolinium, because in patients who have any kidney issues, there can be added kidney toxicity with the gadolinium, and there can actually be some other issues as well with that. But for PET CT, generally considered to be pretty safe from that standpoint.
Okay, thank you very much.
Okay, no problem.
Your next question comes from the line of Leigh Cohn.
Yes.
Hi, my question has to do with what might have been new at ASH regarding high-risk disease, including deletion of 17p.
Okay. Not a lot new, actually. The interesting thing about 17p is that at the point of relapse, that one thing that was emphasized and was discussed a little bit is that at the point of refractory relapse, the 17p is not so important at that point. And this is one of the aspects that I was getting at when I was showing the RAS mutations in that patient that had the relapsing myeloma. It seems like although 17p is very important earlier on and patients are more likely to relapse sooner with the 17p, later in the disease, if there's a refractory relapse, that is usually caused by something else, by some other new, what I call the driving mutation that really is critical at that later time point. And so there was not really a lot of new data. There was some preliminary data that the Southwest Oncology Group is conducting a trial for high-risk myeloma where they're looking at VRD plus elotuzumab, and Dr. Usmani did present some preliminary results on that, where it is working well, but we don't know how much better VRD plus elotuzumab is going to be versus just the VRD. And so not a lot of new data. Carfilzomib, pomalidomide, and Dex is quite good relapse therapy, including for patients with the 17p minus. That has been presented at previous ASH meetings. One other thing that was commented on by a few of the researchers is that it really is quite complicated because there are some patients that have the 17p minus and then other ones have the 414, and then there is this business of having a loss of chromosomes or extra chromosomes. You may have heard of something called trisomies, where instead of having 2 chromosomes, you have 3 chromosomes. And so it's becoming a little bit complicated to figure out these different combinations. I think we're all waiting for some better testing, and I was giving you the idea that we may be switching over to these mutational analyses where we're going to be actually looking for specific mutations in relapse patients that will give us some better clues. Okay?
Okay. Thank you.
Your next question comes from the line of Joyce Boriska.
Okay.
Yes, thank you for taking my call. Dr. Dury, my husband was diagnosed in 2011. He did the RVD and then went in for a stem cell transplant a year later. He had a 2.5-year remission, and then he had a symptomatic relapse here 6 months ago due to a tumor in the back, had it radiated, and now he's been on CRD, and he's had a great response. He has minimal residual disease now. He has 0 M spike.
Excellent.
The doctor wants to send him on to stem cell, but we're wondering if that is really completely necessary. Maybe he'd do better on just staying on Revlimid as a maintenance drug and use that as a card down the road.
Right. So really a very good question, and there were some presentations about second transplants, and in fact, you may be interested, there's a new IMWG guideline that just came out with Sergio Giralt from Memorial Sloan Kettering in New York. We can get that for you. If you call the IMF, we can get you this article on the pros and cons of a second transplant, which I think is quite helpful to think about, okay? And what this article says is that if you've had a remission for at least, in this case, 2 years, that there can be a significant benefit with a second transplant. And so it's certainly a viable option. But the big question, which is discussed in the article, is that with all these new therapies, the question is, how does that second transplant benefit stack up versus maybe about taking like Daratumumab or some other kind of a thing? And then how about maintenance? One question would be, was the Revlimid, there was no Revlimid maintenance before, I guess, right?
He had Revlimid for 1 year after the stem cell, but had GI problems, so he discontinued it after a year. So now the doctor, hindsight, is saying we should have probably stayed on the Revlimid.
Yeah, so that makes it a little bit tricky. Yeah, I mean, certainly you could maybe try a lower dose. I mean, there's not a major time clock possibly on the use of the second stem cell, although, I mean, when we do the transplant, we like to do it at that point of maximum benefit. I think it's one of those pros and con things, but the main thing I would say is that the second transplant idea is certainly not crazy, and if the first transplant was well tolerated, and then maybe a low dose of Revlimid was used after that, there maybe could really be a very sustained benefit. So it's one of those personal things to take some time to discuss, I think. I'd rather not answer it on this conference call. I hope that's helpful.
Okay, thank you.
Your next question. Yes, sir?
Yeah? No,
yes, go ahead.
Your next question comes from the line of Gary Pricer.
Okay.
I was looking at, we were presented with maybe a dozen studies. Really, none of them were very hopeful. I mean, we were dealing with somewhere between 40, 50% remission compared to the losing arm of the study down in the 20, 30% remission.
Right.
So nothing seemed very encouraging, really, and that was only taking it out about 40 months.
Right.
Do you have sort of a cascading regimen that you use for people who fail all along the way into study after study after study? I mean. Yeah,
I think that this is a very difficult situation, and thank you for this question. I mean, this is a very important point. The first thing I would say, which is maybe I hope helpful for you, is that some drugs work well in some patients, so that you can take one drug, another drug, a third drug, and not much benefit, and then suddenly you take that next drug, and that can be a spectacularly helpful drug for you. So just the fact that a number of other drugs have not worked well doesn't mean that that next one might not be really good for you. So we saw that, for example, quite a bit with the Daratumumab, this one that I talked about, the Darzalex, which was just approved by the FDA, where a number of patients had gone through a lot of drugs, very refractory patients, and then suddenly they actually did have a response with that. And so I think that you just need to look at that and see what might be the best next one to try. But certainly, just because a lot of drugs have not worked well doesn't mean that everything is going to be at that level, okay?
And is there a mortality along the way that we didn't see on these graphs? I don't know what the natural history of the disease is.
No, I mean, the graphs include all the patients. I mean, I think that what has been the case for the last 10, 15 years is that a lot of patients have gone from one study to the next, so that, you see these 30, 40% response rates where patients maybe have responded for 1 or 2 years, and then they've gone on to that next new drug and the next new drug. And if you talk to patients, you'll see that a number of them have gone and had remissions of a few years, and lo and behold, it's 5, 6, 7, 8 years later, but that is with the benefit from several different drugs that they've gone from one to the other. And then occasionally, like something like a Daratumumab, they can have a much more substantial response. One regimen that I mentioned earlier, Carfilzomib pomalidomide dex, is one like that, where the average remissions have been over 2 years survival now in responding patients to Carfilzomib pomalidomide dex, in patients who had really poor results prior. So don't give up hope.
Okay. Don't give up, right?
Don't give up, and talk about it carefully. But you, or maybe if you want to call the hotline, I'm sure that someone on the hotline could help you, maybe guide you towards some trial that might be available in your area that could be helpful. Okay?
Thank you very much.
Okay.
Your next question comes from the line of Karen Nichols.
Yes.
Hello, Dr. Dury.
Hi.
I'm hoping my phone won't break up, as it's been starting to do that. But my question has to do with MRD, stringent complete remission. I've talked to my doctors about it. I had a stem cell transplant in January of 2012. I was on a maintenance dose of Velcade up until April of 2015, when they took me off of it in case of developing some neuropathy. So essentially, I call it, I'm now going bare, and they're waiting for the symptoms to return, which makes me nervous. I'm just questioning whether there's something out there for me. Should I be talking more to my doctors about being on one of the newer medications, or are they not for me? They keep telling me the minimal residual disease tests are not conclusive enough. I don't know exactly where to go.
Well, I think that, thank you for calling in. I think that this is a very important point. And so basically that MRD negative, it's not a sure thing. In other words, the myeloma could still come back. We're looking at regimens where we move towards a certainty, where if we get to a certain level, then we know that the remission is going to be really a long one. But the recommendation for someone like yourself would be, if you're doing well, this is not the time at this point to start taking a new drug, primarily because we would not be able to assess if the drug was working. You know, if you were to take any one of our new drugs, we wouldn't know, well, is that knocking down the myeloma? There would be no way to know the value. And so what we recommend for someone like you is to watch closely, and then if there's any indication of disease, this is an ideal time to think about, well, what would be a new drug to use? Now, you see, in your case, you were taking the Velcade maintenance, so this might be a situation where this new drug, the Ixazomib, the Ninlaro, where it would be like a Velcade, but it has a very low level of neuropathy, maybe that would be a type of drug that would be useful, and then would be something that you could comfortably stay on for a long time as a maintenance. But I don't think that you need to launch into that unless there would be some indication of disease, and then we would be able to assess if any new treatment was working. So we don't like to put someone on a maintenance after they've been off or if they're doing well, okay?
But should I be having any other kinds of testing?
Well, I think that, yes. I think that I'm just rushing a little bit. Just because of time, but a PET CT scan is a very good thing to have periodically to make sure that you're not missing something. So I would think a periodic PET CT scan once a year, for example, can be a way to be sure to check up on things. Okay.
Okay. Thank you very much.
No problem. So I think we can do one more, and then we'll take a final wrap-up here. So one more quick question.
Certainly. Your last question comes from the line of David Bloom.
Yes, thank you, Dr. Dury. It was an excellent presentation.
Thank you.
P53 deletion.
Yes.
Two exciting new molecules out there.
Yes.
And I'm just wondering that in selecting the people for those clinical trials, did they give any attention to P53 deletion, whether any of these drugs are more effective for patients with P53?
Well, the main one was the Daratumumab, the Darzalex. It was tested in the relapse refractory patients, and it was definitely active in patients with the P53 mutations, which is the patients with the 17P minus. So yes, the Daratumumab was definitely active in this subset of patients. Okay. And as I said, also the other combination is the carfilzomib Pomdex is active in that setting as well. The elotuzumab and the Ixazomib, that was not so clear. That was in the combination trial. Okay, so, this is obviously a key thing with all of the new drugs to see if it will work in that subset. Okay.
Okay, thank you very much.
No problem. Okay, well, we're going to have to stop there. And so thank you very much for your attention tonight. And yes, so a couple of things. For those of you with further questions, or maybe if you didn't get the slides or whatever, please contact the IMF, and Susie's going to talk about that. And then we have some polling questions before we finish up. So perhaps we can go to the polling questions first.
So, Victoria?
Yes.
All results have been tallied. Do you have any closing remarks?
I do. I just want to thank Brian. I think it was really wonderful. And I'm sure everyone on the call tonight really appreciated your update. And most of the listeners will probably have some follow-up questions. So again, if you do, don't forget to call our info line. They're here to help. That toll-free number is 800-452-2873. And again, I want to thank our sponsors, Amgen, Bristol Myers Squibb, Celgene, Janssen, and Takeda Oncology. Another good way to stay abreast of everything is to attend one of our patient seminars. We do 4 a year, and the first one will be held in Boca Raton, Florida, February 26th and 27th, and the next one will be in Seattle, March 18th and 19th, Philadelphia on April 8th and 9th, and finally in Los Angeles, August 19th and 20th. And if I spoke too quickly and you couldn't write it down, just call us and we'll give you those dates. So again, thank you all very, very much. Thanks, Victoria, and be well, everybody. Good night.
Thank you, everyone. Good evening.